I'm David Steensma from the Dana-Farber Cancer Institute in Boston, Massachusetts, and coming to you today from the Great Debates in Hematologic Malignancies and Updates in New York. I chaired the sessions on acute leukemia, myelodysplastic syndromes and myeloproliferative neoplasms, not so benign hematology, non-malignant hematology that certainly is clinically problematic, and on CLL, chronic lymphocytic leukemia. In many of these areas, we are seeing some major changes in how patients are being evaluated and how they're being treated. For instance, in acute myeloid leukemia, where for many years for patients who were good candidates for intensive therapy, we've used the same regimen, 3 and 7. We now have data that my colleague Rich Stone summarized about adding targeted agents, including the FLT3 inhibitor midostaurin. There's also data for sorafenib, to chemotherapy, improving both event-free and with midostaurin overall survival in those patients. In the CLL space also, we had a debate, really more of an exploration of 3 different approaches to the difficult subtype of patients with chromosome 17p deletions, a very high-risk subset. Jacqueline Barrientos from Hofstra, North Shore, Long Island Jewish, spoke about the role of ibrutinib in that setting. Paul Barr spoke about novel agents. And Ted Allier, a transplant specialist from Dana-Farber, talked about where allogeneic transplant fits. CML is a disease that there are many effective treatments for, but still a number of clinical questions. And Jerry Radich from Seattle highlighted some of the stopping studies. Something patients commonly ask is, when can I discontinue my TKI? And he also talked about molecular monitoring of patients and how those patients should be studied. In the chronic myeloid disorders, particularly in the myeloproliferative disorders, we also have some targeted agents. Ruxolitinib is the one that's approved for higher risk myelofibrosis and for polycythemia vera that's refractory to or in patients who are intolerant of hydroxyurea. But JAK inhibitors are being combined with a wide range of agents, including PRM-151, an anti-fibrosing agent, pegylated interferon, hedgehog pathway inhibitors, and a large number of other agents to try to improve outcomes for those diseases. And Ruben Mesa from Mayo, Arizona summarized those data. We had a presentation from Eric Padron, who talked about the difficult group of myelodysplastic myeloproliferative neoplasm overlap syndromes, and these are traditionally a challenge to diagnose accurately. He spoke about atypical CML, about CMML, about chronic neutrophilic leukemia, and what we know about the biology and what little data are available about treatment in those areas. Almost exclusively based on small series and case reports. Tim Call, a very experienced clinician from Mayo Clinic, talked about some of the practical considerations for use of newer agents in CLL, including ibrutinib and idelalisib and some of the other agents that are coming along. Given that these agents are in place now in CLL, Matt Davids from Dana-Farber and Rick Furman from Cornell debated whether MRD status or deep remissions are still essential in CLL for patients to benefit from these agents, and the data are somewhat mixed in that area. Another debate in the sections that I chaired was between Gail Robas from Cornell and Selena Lugar from Penn, and they talked about hypomethylating agents, azacitidine and decitabine, which are a critical part of the therapy for higher risk MDS patients. What really is their role in lower risk? They're accumulating data that they may have benefit for some patients. On the other hand, if you use the agent when the patient has lower risk disease, maybe then you don't have anything available at the time of disease progression. So they discussed some of the nuances there. So this just gives a sort of summary of some of the challenges that we're facing and some of the new agents that can help us treat our patients with malignant neoplasms. The final malignant neoplasm presentation was by Rafael Behar, who's done so much work in defining the molecular genetics of MDS. And now that clinicians are able to get these molecular genetic tests, it's really made us have to have a rethink about which patients have MDS, where is the borderline between clonal states that are common, clonal hematopoiesis of indeterminate potential, so-called CHIP, in older patients, versus true disease that is likely to progress over time. Finally, in the non-malignant, the non-neoplastic hematology, we had 3 presentations. One from Ken Bauer talking about new agents that are approved for reversal of the DOACs, the newer anticoagulant family, of which there are now 4 agents approved. Second, Sarah Nikiforou from Dana-Farber talked about HLH, hematophagocytic lymphohistiocytosis, an increasingly recognized condition for which our treatment is really quite inadequate, often triggered by malignancy in adults and by inborn mutations in children. And then finally, Jim Bussell talked about ITP and the newer approaches. He spoke quite a bit about eltrombopag and romoplastim, but also about new combination immunotherapy approaches to try to get a deeper response. So I think that really summarizes some of the key presentations. It was really a very exciting set of presentations with good audience participation, and this was, I think, a good learning experience for the clinicians who participated. Thank you for your attention.